I'd like to welcome our participants to the Antimicrobial Stewardship Project webinar series today. I'm Dr. Marnie Peterson, and I am the outreach coordinator for the project, which was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. We are pleased to have two speakers today, Dr. Brandon Bookstaver and Hana Rac, as our speakers today for the webinar titled, as you see there on your screen, Penicillin-Allergy Skin Testing, Decision Points, and Considerations for Institutional Implementation. And they've both been very active in this space, and so we're very much looking forward to their input. This is an important topic, and I just want to bring to everyone's attention that tomorrow on September 28th is the U.S. National Penicillin-Allergy Day. This day has many national sponsors. It's hosted by a company, ALK, along with national partners, IDSA, and the American College of Allergy, Asthma, and Immunology. So this just really highlights the importance of the topic and to try to raise awareness around the impact of carrying a penicillin allergy label and how this can affect a patient's healthcare treatment and decision-making. Our two presenters today, as I mentioned, are Brandon Bookstaver. He is an associate professor and director of residency and fellowship training at the University of South Carolina College of Pharmacy. He maintains a practice site in infectious diseases and antimicrobial stewardship at Palmetto Health Richland in Columbia, South Carolina. He also serves as co-director of the Southeastern Research Group, otherwise known as SURGE. Hana Rac is a clinical instructor at the University of South Carolina College of Pharmacy, and she practices as the lead antimicrobial stewardship pharmacist with the Antimicrobial Stewardship Collaborative of South Carolina. She graduated from the South Carolina College of Pharmacy, and after graduation, she completed a PGY1 residency and a PGY2 infectious diseases pharmacy residency at the University of Mississippi Medical Center. So two very experienced, and we're very looking forward to our speakers today. For our participants, just a few instructions here. You're encouraged, and we really want to engage with you. So we really encourage you to submit questions and comments through the chat box, which you can see located at the bottom right-hand corner of your screen there. And please sure to send your questions or comments to all the panelists, and we will have time at the end of the webinar to address and engage in a discussion. And a final note is that the webinar will be recorded, so if any of you would like to share this with any of your colleagues, we will have it posted to our website via a YouTube channel. So with that, I'd like to welcome Dr. Bookstaver and Dr. Rac to join us today and begin their presentation.
Thank you, Marnie. We really appreciate the opportunity here, and just want to not only thank you for hosting us, but all the stuff that y'all at the University of Minnesota and CIDRAP and that do for stewardship and others. It's to be commended. So we really appreciate the opportunity to be here today and talk through a few things. Thank y'all for joining us. This will be a little bit different maybe than a traditional webinar that you're used to hearing. We're gonna both be bouncing back and forth a little bit and have a little bit of dialogue with you, so hopefully it'll be a little more engaging and can follow along a little bit. These are our disclosures. And an official agenda today, I want to make sure that when you're attending, you know what you're going to get out of today. We aren't going to do a deep literature dive. We're not going to try to convince you a lot about cross-reactivity and penicillin allergies and what's IG-mediated and not. We're really going to spend a lot of focused time on logistics of implementation. And we're going to walk you through how we did this at our teaching hospital in South Carolina and Columbia at Palmetto Health, and give you a little bit of the ideas of your target population, preparation, leadership structure, some resources, and even touch on some state regulation information as well. So with that said, if you're thinking about numbers, just remember the 90-10 rule. It's no longer the 80-20 rule, it's the 90-10 rule. So 10% of people, that's about 30+ million people in the U.S., or in South Carolina, that'd be about 500,000 people are going to report a penicillin allergy, but 90% of those are either not truly allergic or certainly don't have a serious reaction, which sets us up for a very common problem that leads to some issues that y'all know about, but let's talk about a few of those issues. So, for example, we know that beta-lactams are preferred therapy, and I think this goes without saying. We're not going to belabor this point, but many of these that are on this screen, invasive MSSA infections, syphilis, H. pylori, intercoccal infections, surgical prophylaxis, and more, these all have either a penicillin or penicillin derivative or first-generation cephalosporin closely related that are their primary guideline-recommended first-line therapy. And we know what the alternatives lead to. So what does that mean for our patients that have penicillin allergies? Well, there's a number of risks that are associated with penicillin allergy, and this has been pretty well documented. Kim Blumenthal and her group has published a couple of articles recently in CID and BMJ in 2018. But surgical site infections, 50% increase for those patients who have a penicillin allergy. And in their analysis, it really teased out that most of that was due to receipt of alternative antibiotics like clindamycin or vancomycin. You're going to increase use of alternative antibiotics that you may or may not want to be using. This is a study from our group in pharmacotherapy, four-time odds of receiving carbapenems for those patients with mostly with gram-negative bacteremia in those who had penicillin allergies versus others. But and you've seen this data documented, patients will receive other alternatives, whether that be vancomycin, fluoroquinolones, clindamycin, aminoglycosides, et cetera, which all are associated with their own known risks. And then lastly, most recently published in BMJ, this increased risk of MRSA and C. difficile infection. And this should make sense to you. If you're receiving alternative antibiotics, which we know are higher risk antibiotics, such as fluoroquinolones or clindamycin, many of these things, especially with C. difficile infection, would come with an increased risk. And again, in the sensitivity analysis in this study, they were able to show a correlation, not just to, hey, you have a penicillin allergy, so you have an increased risk, but more so because of the receipt of these alternative antibiotics.
Okay, so we wanted to talk a little bit about some of the strategies that can be used in optimizing care for the patients that have penicillin allergies. Some of those include having an allergy reconciliation that's really intensive, that's performed by the clinician, and we'll talk a little bit more about that later. Then there's the education to providers on the risk of cross-reactivity with cephalosporins and related antibiotics. Because the cross-reactivity is fairly low, so many of these related antibiotics can be utilized in these patients without doing any sort of further testing. And then implementation management pathways that address penicillin allergies. So by this, we don't mean start putting all of these patients on estreonam or fluoroquinolones or alternative antibiotics. This would be more like developing pathways such as desensitization or graded challenges. And then there's the oral challenge, which can be done with oral amoxicillin or penicillin, which we'll kind of briefly touch on, and then the penicillin allergy skin testing. So today we're going to focus on implementation, specifically more so with the allergy reconciliation and the penicillin allergy skin testing implementation.
There's a lot of data out there about penicillin allergy skin testing, and you've probably seen this. But again, we're not doing a deep literature dive, but I want to draw your attention to a few things. One of the big things we're going to talk about in the next couple of slides is how you pick your team, because one of the things to decide on at the very beginning is who's going to do this? If we're going to do penicillin allergy skin tests in our institution, who is going to execute it? I put 3 examples up here of pharmacist-driven, ID fellow-driven, and then nursing-driven with pharmacy oversight. So there's very different applications here, and we're going to talk a little bit about the differences and how we chose the direction we chose at Palmetto Health. When you look at the guidelines specifically, they do mention penicillin allergy skin testing, of course, with the grade evidence criteria that has to be used. It's going to come with low quality of evidence and weak recommendation. But they do highlight, the expert panel, they do highlight that if you have the ability to do it, that using penicillin allergy skin testing can enhance your use of first-line agents and can help you optimize penicillin allergy skin testing. We're going to give you some really pretty good hard data on that from our group on how we've been able to make major antibiotic changes for some of these patients.
First, we're going to briefly review some of the logistic factors that can come up when you're planning on implementing penicillin skin testing at your facility. So one of the first things you really have to think about is your target population. So while, of course, we would love to test all patients with penicillin allergies, that's really not feasible, especially with the available resources. So the first thing you have to think about is developing your criteria. So we're going to talk a little bit about what we did or what we decided on later, but some things could be patients that are already on suboptimal antibiotics, or those maybe restricting to certain wards or IV consult patients. Another logistic factor would be optimal preparation. So that would be the development of your testing kit, and that can be either prepared in the IV room or it could be prepared in the patient room. So that's just something you have to consider at your facility. The leadership structure, so who's really going to take ownership of it. The resource availability includes both time, personnel, and material limitations. And then, of course, every state is going to have specific regulations that they have in place about this, so that may affect who's doing the penicillin skin test, among other things.
Just to give you a quick background, jumping into our implementation here at Palmetto Health, this really started in 2015. So you may look at this and say, man, we're not going to take 3 years to do this. These folks down in Columbia are pretty slow, and that's fair. That's a fair statement. But I do want to give you an idea that this doesn't happen overnight. So this actually was born out of a stewardship orthopedic work group that we have at our hospital that we address certain issues related to surgical site infection, surgical prophylaxis, even our open fracture protocol. So we did a really deep dive in the literature, really talked through the concept with this small group. And that started back in mid-2015. And we started having conversations with other programs that do penicillin-allergic skin testing. I think that's a very important thing as you embark on this. What are other people doing? What are their successes and their pitfalls that they've been able to either avoid or learn from? We talked with our allergy group. This is obviously an important group to have on board. We do have an allergist on site. However, the allergist is primarily outpatient, does very, very little inpatient, just due to primary role and patient demand. But these were early engagements to make sure that this was something that we were going to have support from. From there, we really engaged our pharmacy group and our IDDST, which is a drug specialty team that's interdisciplinary, and it's a subsidiary of our Pharmacy and Therapeutics Committee. We were referred then to the Board of Pharmacy to really talk through this inpatient pilot. This abbreviation you see here with PHASSC, not to be confused with our PAST. This PHASSC, which is FAST, is our Palmetto Health Antimicrobial Stewardship and Support Team. We define that a little bit later for you, but we really wanted to engage in an inpatient pilot through our stewardship team. Well, when we presented this to the board, we found, and did a little bit deeper dive, we did find out that pharmacists, and we'll talk about why we chose pharmacists in a second, but we did choose pharmacists as our delivery personnel here for the skin testing, were really not authorized, if you will. They weren't prohibited, but there's certainly nothing specific in there. So we sought approval for the Board of Pharmacy, and we did receive this in 2016. This required at least 3 different presentations to the Board of Pharmacy, Board of Nursing, medical examiners, and a healthcare consortium committee, receiving approval from all of those in 2016. Now, our hospital had decided that we had to have approval from those folks before pursuing any further, meaning we couldn't take the other steps in the background to have informatics working on protocols or even get P&T committee approval, because we really had kind of stopped at the point of engaging our pharmacy leadership, and this was the next step. So we were doing things behind the scenes, don't get me wrong, but we weren't able to achieve other approvals until starting really around November of 2016. We received approval from our P&T committee there, and we started our live training on site. We'll talk about training in a second for our select staff. Ultimately, the program that was built into our Cerner, which is our EHR, and our IT build was fully completed a little bit later in the year, and so we were pleased with that. We were able to launch roughly in that mid time point of 2017. Our official launch date wasn't until September. We had a soft launch between July and September. But then most recently, which we're excited to add, I spoke on, we received approval from the Board of Pharmacy. That was, and nursing and medical examiners. That was a 1-year pilot project, and we were required to come back and bring data to them 1 year later. What's happening? How does this look? And We did that earlier this year, and in June of 2018, after presenting in April of 2018, we received final approval to remove the restrictions of our pilot project, and now this is available outside of the constraints of just our hospital and moving forward even outside of just our inpatient population. So it was a little bit of a journey here, and I think this is important to note, though, because it does take time to get these things through, and something that you have to be engaged with. It does speak to one of the first topics that Hana mentioned on state regulations as an important logistic factor here. Going beyond that, our official launch was September 28, 2017. No, that's not a misprint or when we did these slides. We do know it's 2018. But this was National Penicillin-Allergy Day, as Marnie mentioned, and so we decided to make this kind of our full official launch, even though we had a soft launch and we're already doing a few of these prior. So we're officially 1 year out. We're about 14, 15 months out from when we actually started doing these of our pharmacy-administered protocol. We are pleased to say that we're one of the 4 states, to my knowledge, as of today, that has also received the Governor's Proclamation for Penicillin Allergy Day, so I do encourage you. That may seem less important or more important to you, just depending on your opinion, but I certainly think it carries weight when you're presenting things to your institution or a college or other outside governing body who may have ties with that particular group.
All right, so now we're going to go into a little bit onto our training process. So, of course, one of the decision points that every institution has to make for themselves is who to train. So at our specific hospitals, we decided to go with the pharmacy path, but the other options, of course, as mentioned before, could be nursing, the infectious disease team, other medical providers. However, all of that, of course, has to be based on resource availability, state regulations, et cetera.
One thing I want to add about that, if I can, we decided, one of the main reasons we decided on pharmacists was we had a lot of momentum with our pharmacy team who was behind this. So if you're going to have good buy-in and you're going to have folks that are excited to do it, that makes sense to me. You know, have those folks doing it. We also, from an ID fellow perspective, there was really no way that they could have added burden on their schedule. We have 4 ID medical fellows, 2 in our first year and 2 in our second year, and they're really, really stretched. So we decided that wasn't an option. And the nursing option for us was not as attractive because we felt we would have to retrain nurses very frequently to do this. And we also kind of have a duplicative work conflict of interest at our institution, meaning if someone is doing it, having 2 people there to do it when one can do it is kind of seen as a conflict. So we felt that if you had multiple people having to do hands-on things at the same time when one could do it, we were really pleased with that. So that was one of the main things that we decided there. The other thing I want to mention while we're on this slide, if I can, Hana, is what we did to train these folks. I mentioned that we brought in a training thing. We'll mention to you at the end about a potential in the future of certificate program training. But we had our official training, which was offered through AOK on site. We required our folks to have BLS certification, and they have to do 2 actual bedside skin tests every 12 months to stay certified. So all these are documented in a log that we keep so that we could present that to the board at any time. But it gave us a chance to give us an official way to train these folks.
So after the training, the next decision point that we really have to make is the timing and the availability that you're going to actually offer these at your institution. So particularly at Palmetto Health, in the initial introduction of this program, we really had it more as a stewardship-driven initiative. So for that reason, we were including patients that were screened by our stewardship and support team. And of course, looking at they had to have a history of a reaction to a penicillin or a derivative marked in their medication record, or their EMR. And then the service we made available Monday through Friday from 7 a.m. to 4:30 p.m. And that is really because that was when our stewardship team was available. So this may be different at your institution depending on the hours that you have, whoever is doing the penicillin skin testing available.
Yeah, it's not we didn't consider it an urgent thing. That was a question from our Pharmacy and Therapeutics Committee. But we decided that there are alternatives available. And to be honest, we have done them outside of these hours. But this is when we promote the service to be available, when it was deemed to be really more urgent than non-urgent.
So once we identify the patient, we utilize Cerner. So a Cerner consult for penicillin skin testing would be initiated. And this is just an example of what that would look like. And this could be either put in by the provider that wants us to take a look at the patient, or it could be put in by the stewardship team after we reach out to the providers about the patient that we get flagged on. Then after that consult goes through, an alert gets sent to our stewardship team. And this is what that alert would look, or the alert gets sent to the provider, who then has to contact our stewardship team, as you see specifically on this alert.
It shows up one other place too, which is neat, in the verification field. So if our centralized pharmacists are verifying, they would get this message to alert stewardship. We had this built in as kind of an extra safe step. It's very difficult for our providers to always find the order set per se to enter. But if they do, and they, for some reason, stewardship or ID consult team was not involved at all, and it was, was unknown, this was kind of a safe fail to make sure that we had notification of stewardship for this consult.
So the next step after we identify these patients is the screening and reconciliation. So if the stewardship team were the ones finding these patients, they would have to contact the primary physician during the hospitalization to really discuss the reasoning of wanting to do this penicillin skin testing. And then before doing any sort of penicillin skin testing, they would also evaluate concomitant medications that may interact or potentially exclude the patient from receiving penicillin skin testing at that time. And then the really major part that we want to focus on here is the intensive allergy reconciliation. So we did not want to do penicillin skin testing on all patients based on some of the factors that we mentioned before. So resource availability, we can't be doing penicillin skin tests on everybody. And also many patients would qualify to receive the first-line beta-lactams solely based on the allergy reconciliation. So it may not have been a true allergy. And you can sometimes just figure that out from talking to the patient.
Yeah, while not everybody is going to be trained and can or want to do the actual skin testing, every clinician and others can do intensive allergy reconciliation. And one of the things that we've noticed is a little bit of a culture change at our hospital. It's allowed us to have almost a pre-performed intensive allergy reconciliation in some combination. Like, it won't always be the nurse or the physician or the pharmacist, but in some combination that has been performed. And it can be time intensive. So it sometimes is a shared responsibility, but it is something that is very, very important when you're evaluating these particular patients.
So I mentioned selecting the target population and how we were going to discuss what we initially did. So for our pilot that we initially did, we excluded outpatients, pediatrics, those that weren't currently receiving or anticipating antibiotics, anybody that was unable to consent, as well as pregnant people, patients that had certain penicillin allergies, such as if they had Stevens-Johnson syndrome, PEN, or DRESS syndrome, and then patients that had anaphylactic reactions within the last 5 years. However, you'll see some of those have asterisks on them, and we'll likely be moving towards doing more of those patients now that we are expanding.
We'll talk about expansion and where we're moving towards the end of the presentation.
So this is our Cerner predefined order set that gets popped up once we're entering the penicillin skin test. So after we decide that that patient is going to receive a penicillin skin test. You'll see that you have to select your kit content. That was one of the logistic factors that we mentioned before. And at our particular institution, we chose to go ahead and individually draw up these materials in our IV room and then have them make them. We chose to do this specifically during our first shift, and that's because it fits best into the workflow. However, at your institution, you may choose to do it differently. And then some institutions also actually send up the vials and assemble the skin tests in the patient's room. So that's another option if that works best at your institution.
There's also a commercially available kit as well. We chose to, while we use the pre-pen product as part of our kit, we did choose to assemble our own kit through the different materials, which include a number of other things as well that aren't listed here. Something, including markers, including the ability to actually do the skin prick test itself. So those materials in the kit, we actually do make our own bags, and it's really nice, like Hana was saying, because these orders are done, and one thing that's important is we also had to talk very intently with our centralized pharmacy group. The orders are actually entered during the hours of first shift. They're all made and entered during first shift because that's where our pharmacy personnel and services and central pharmacy and ID room could actually make the product. So if we're entering an order at 5 p.m. the day prior, it's going to be made and prepared during first shift the next day. So there are some logistic things you may want to work out. Fortunately, the numbers are not usually burdensome. However, if your institution is doing a lot of these or has outpatient and ED as well, or has a very large institution, it could become somewhat burdensome.
And as you see at the bottom of the screen, there's the oral amoxicillin challenge that's optional at our particular institution. Some institutions have made it more of a mandatory second step after you have a negative penicillin skin test, but that's just another one of those decisions that you have to make at your facility. So the next step is, of course, obtaining verbal consent from the patient. So at our institution, the written is really inferred from them giving consent for medical care. So we just get verbal consent from the patient, and then we actually perform the penicillin skin testing. So the scratch test, which you'll see on the left, and then the intradermal testing on the right, and then we interpret the results and enter it into the medical record.
One of the things that's interesting here, before we jump too much into the documentation phase, and I'll just take one step back, is when you do pharmacist personnel, pharmacists are not always used to entering things in the MAR. And so part of our training was very intently on barcode scanning for the patient and for how to enter things in the MAR. One of the early returns that we got from one of our trainees was, I had the barcodes have wrinkles in them. The things we hear said from other folks who are using the MAR system or the barcode scanning, so we didn't scan it. Well, our med safety officer gets alerts on all the scanning, and when we have delinquencies, of course, they come back to us. So I think that's an important thing is, what are the things that are going to be out of the ordinary for whichever personnel you choose to use? Is it going to be calling a pharmacy? Is it going to be documenting the EHR? Is it going to be the actual technique with intradermal testing? Whatever that's going to be, make sure you're analyzing that early. And some of them will be unanticipated, but make sure you're trying to look at that early in the process to understand where those nuances may be so you can include those in your training.
Okay, so the documentation is the next step, and then, of course, informing other key providers. So patient education is very important because the patient needs to understand that if they have a negative penicillin skin test, that we are removing the penicillin allergy from their medical record. So that means that they can receive penicillins from that point forward. And if the patient doesn't understand this fully, then they will likely go further in their medical care, perhaps with another provider, and once again report their penicillin allergy. And then informing inpatient and primary care providers. So the inpatient provider, we actually have a template note that we leave in our electronic health record that discusses the penicillin skin test that we did and the results to it. So that is in the medical chart, but we also contact the primary care physician and any other consult services such as infectious diseases of the results. And at that point, we also provide recommendations if we do want to change them to any sort of beta-lactams.
Yeah, this is so important. When you're doing the actual test in the room, at best, you're talking 45 to 50 minutes, but you have a little downtime. you know, if you're doing the two-step test, the traditional test, and we showed you pictures of those, again, it's kind of beyond the scope of this to go through the actual testing with you. But you have a 15 to 20 minute waiting period for each time frame. And that is a great time to do some of these exact things. You know, talk more with your patient. Also, not only that, who are their primary care providers? You'd be surprised how inaccurate data are in the electronic health record, because a patient may have a primary care physician that they haven't seen in 15 years, but they have a cardiologist that they see every 6 months. Well, that person would be a more important contact. What about dentists? Unfortunately, we've had about 170 people in our study that we've screened, and I hate to say, but I'd say about 15% actually have a permanent dentist. But regardless, dentists is a great group to engage. Dermatologists. These other providers are really important, and this is something that we try to do a really good job of, and we'll show you some screenshots on the next few slides, of giving them the information so they can update their records, because that bottom bullet that we're going to talk about in just a second is so very important.
So this is the example of our patient education card that we actually fill out and then laminate and give to the patient so that they have documentation of this negative penicillin skin test, or positive if that patient happened to have a positive test. And this way they can show this to their pharmacist, to their providers. We will be reaching out to those people ourselves, of course, but just so that they have it to show other people.
Everybody likes a pocket card.
And then we also back the providers that Brandon mentioned before, so the dentists, the primary care physicians, any of those specialists that they see regularly, just to let them know, you know, the patient had the negative skin test and that from that point they are eligible to receive penicillin and related antibiotics. So the next steps would be updating the inpatient and outpatient pharmacy records. So, of course, we would update, and I'll kind of show you how that is on the next slide, but we're going to update the hospital pharmacy records, so taking out their allergies, as well as we call their outpatient pharmacy to make sure that they are aware that the patient's penicillin allergy can be removed from their records. And then one of the most important things is preventing that redocumentation of the allergy, which will show you what we do. So this is what we put in for their allergy. So we mark the allergy as resolved on the medical record, and then we put in a comment on there, and the comment says, you know, the patient had a negative penicillin skin test on this day, you know, we're updating the allergy, and of course they can look at the EHR note for more details that we left in the medical record. And then we also provide our stewardship pager number in case they have any specific questions with regards to that.
And Hana, I mean, that's so key, because one of the things that comes up often as a question is, well, yes, this was great, you did this test, but then they're going to come back to the emergency department 4 weeks later and report a penicillin allergy, and there's worry that you're wasting a test. And there is a little bit of data out there on some places. One group out of Savannah I know has looked at that and, you know, had some pretty good success, but it's certainly a problem and something you want to pay attention to, especially folks who have frequent contact with either inpatient or outpatient providers that are in your system, because there's the ability to update both of those records if they're separate, or if they're joint, it could be updated by someone in the outpatient arena that will transfer over to the inpatient. The other key word you used was resolve, and I like that. Just remember, when we say removing allergies, it doesn't delete them from the system. Like there's still a record of those, but the display of active allergies does not show these anymore. So they're resolved, meaning they're still archived. You could find them, but they're now in an inactive display if you see that in the top right of the screen. Now, if you have Epic or some other type of EHR, there's certainly mechanisms like this to do it. We're showing you Cerner as an example, but there certainly are mechanisms to be able to do that. Now, I mentioned how key it is to prevent that redocumentation. So this is a key slide, I think.
Yeah, so one thing that we really try to do to prevent that is we actually enter in a new allergy for the patient. So we type this in, and it has to be done specifically at our institution by a pharmacist in Cerner, but we type in negative penicillin allergy skin test. So that way, not only does penicillin not show up under their allergies at the top of the electronic medical record, but there's a clear documentation that a negative penicillin allergy skin test has been done. So that way, if the patient happens to forget or not think about it and reports that penicillin allergy, again, before the provider can even enter in the penicillin allergy, they will already be alerted that a skin test has already been performed.
And we've had great success with that. And one of the things we noticed too is the physicians, if kind of as you alluded to, and any of the providers, if people are in a hurry to make decisions and you've got extra clicks to get data, they're not going to make extra clicks to get data. So that's one of the things that this prevents, is they're not having to do extra clicks to get further data. Just to give you a little bit of our preliminary data, this will be significantly updated with full data, but it's embargoed right now because it's going to be presented at the American College of Clinical Pharmacy Global Conference later in October. But this just gives you an idea of some of our preliminary data through July. And I want to highlight a couple of, I think, are really important things when it comes to penicillin skin testing and how this ends up playing out in your institution. One of the big questions we got was, what do you estimate is going to be your workload? What do you estimate is going to be your number of consults you get every week? And we gave them a number, and we were pretty close. We thought that we might do 1 to 2 a week. Some weeks it's 5 and some weeks it's 0. But I think there's an important reason why that number is what it is. So 146 consults and at this prevalent or point prevalence right at July 1st of 2018. 110 of those did not require penicillin allergy skin testing. And the majority of those were because we were able to reconcile the allergy just through intensive allergy reconciliation. Perhaps it was, a GI upset when 15 years ago. Or perhaps even the antibiotic was incorrect when we went back to identify it in records. It was reported as cephalexin or it was reported as amoxicillin and penicillin, but it was actually azithromycin that the patient had. In reality, wasn't an allergy anyway, but these are many opportunities. About 25% of them had some exclusion criteria that were listed, and then a few other reasons, mostly because the patients refused. But you can see of the 36 tests that we included in this preliminary data, we've had no positive results, 32 negative, and 4 indeterminate. What that means indeterminate is that the patient did not react to the positive control. Histamine is your positive control in this test, and so the patient did not react. We're looking at this subset, and I joke because the only thing that we've been able to find is a variable that's associated is the person who delivered the test. It was one of our trainees, but we just joke. It's not really, it doesn't associate. But 80% of people had an antibiotic optimized after their skin test. That's a pretty good number. So if you're looking to give feedback back to your institution, this is valuable. I'm not saying necessarily our data, but your own data when you do this. So a plug here, we need more research in this area, but we also need I think it's important for you to collect your own data and to report on this, because every institution is different, every population is different, because your culture of antibiotic use, your culture of of allergy reconciliation, and your culture of stewardship may all be slightly different per institution, which can affect both your volume and potentially your outcomes. So as just an example, again, trying to be a little vague on giving you all the data here on purpose, because we do have this in a lot more detail that I encourage you to look at. But these are real examples that we've had that have made, we think, a significant impact. I don't think you have to reprove things. So, for example, MSSA bacteremia, for those of you who are clinicians on the call, you understand that nafcillin and cefazolin, these are primary therapies that have plenty of data that they're superior to vancomycin for outcomes. So we don't have to reprove that we're helping patients and improving their outcomes necessarily, because I think that's very clear. But we do know we're able to switch these folks over. We've had some other bacteremias that are important. We've had some interesting cases too, H. pylori. This is going to be a budding area for us that we'll mention in the expansion part. But, the patient wasn't started on any combo yet because we really wanted amoxicillin to be part of that regimen. And so that was an opportunity to be able to streamline them. We use this in some of our other patients too who have been on combo therapy that we've been able to get them down to single agent. So some real good tangible examples that we feel good about, that we're not just doing it to do it, but it's actually meaningful when we perform the penicillin skin test, because it is an investment.
So now I want to talk a little bit about expansion of our program. So as we mentioned, we were really just doing a pilot before. So now we really want to train more pharmacy personnel to allow to expansion to various populations. So we're training our ED pharmacists so that we can start utilizing this in the emergency department. We are trying to increase this to be all hospitalized patients so that all providers would be able to reach out to us with these consults rather than just patients that happen to be flagged by Stewardship or seen by the ID consult service. We also want to expand to OBGYN, which I'll touch on the next slide, our other campuses, and outpatient clinics. So there has been some evidence of this being utilized in outpatient clinics, and we're also starting a protocol for our outpatient elective hip and knee procedures. So we will be seeing some of these patients with the penicillin allergies that qualify for penicillin skin testing after allergy reconciliation at their pre-op visits. And then pediatrics. So there's growing evidence specifically that penicillin skin testing can be used in these patients. And like adults, there's evidence that most of the patients that do get these penicillin skin tests do end up having negative skin tests. As you know, many of the childhood illnesses, such as strep pharyngitis, have penicillins as first-line agents and are going to be more likely to have negative outcomes if those antibiotics are not utilized. The American Academy of Allergy, Asthma, and Immunology has actually stated that penicillin skin testing is safe in pediatrics for over 4 years now. So it's definitely somewhere that we want to go.
I completely agree with that, and I'm excited we're heading this way. One of the things I alluded to with H. pylori, we're also exploring an opportunity with our GI providers who manage a lot of our H. pylori infections as to if this is an opportunity for us to really make a difference in that care, and if we can partner with them. So these are, I think, some great opportunities that we have. They're actively expanding right now. This is not something for the future. This is something that's ongoing as we sit here today.
So I mentioned expanding to our OBGYN. So up to 20% of pregnant patients actually report a penicillin allergy. Some of the main reasons that these pregnant patients would be receiving penicillins would be group B strep prophylaxis, as well as receiving cefazolin for pre-op prophylaxis if they have C-sections. So we are considering doing these penicillin skin testing for some of the pregnant patients prior to delivery. One facility we found did implement penicillin skin testing followed by an oral amoxicillin challenge in their penicillin-allergic pregnant patients. And of the 53 women that they tested, they were all negative for penicillin allergy. Of the 44 who delivered, 30 of them actually did require antibiotics at the time of delivery. And all 30 of those ended up receiving appropriate antibiotics. So the authors actually reported that it was feasible in the pregnant population, and they actually did increase the chance of getting appropriate antibiotics. So it's definitely a good point for expansion. Some future directions that we have is we really want to educate statewide on allergy reconciliation through the Antimicrobial Stewardship Collaborative of South Carolina. And we also want to increase this access and education to other facilities and healthcare providers. So we actually are going live with a penicillin allergy assessment and skin testing certificate program. And this is a nationwide program that we are putting into place, and you can access it through the website there and just look for the penicillin allergy assessment and skin testing certificate program, which will be on the left-hand side. We also have a Twitter handle that will go along with this, with PCN_allergy, that you can follow for any up-to-date information on that, and a LinkedIn group that you can join as well. We will be providing access to the penicillin skin testing for non-hospital settings as well. So we want to reach out to those physicians' practices, nursing homes, and long-term care facilities, as well as potentially expanding to outpatient pharmacies. So there's a lot of room for expansion. Yeah,
I think this is a great opportunity, because determining how you train your your personnel at your institution is going to be important, and how this is sold and articulated. Because yes, certain clinicians, nurses, physicians certainly know the technique, and it wouldn't be hard to teach them the technique, but there's more that goes into it as far as allergy assessment, application of this, interpretation, how you build your program. So there's some opportunities there. The non-hospital settings, this is something that certainly can be on the horizon. I think that there will need to be some details worked out here, but you can see hopefully how long-term care facilities might have an excellent opportunity to participate in this. This could be driving practices quite a bit. All right, I think we're wrapping up here at the end here, but I first want to thank everybody for attending. This is something that we think is a valuable opportunity to impact patient care. We provided you just one example of institutional implementation and some decision points and things that, to get your brain thinking when you're considering this. To reiterate a couple of key points, and then we have some questions to get to over here. I certainly think you should engage not only the folks that you normally engage at your institution, but perhaps you don't talk with allergy a lot. Perhaps you don't talk with your outpatient orthopedic surgeons very much. That would be an important group to engage when you're going through this. Regulations, not only local, but at the state level, those are certainly important and certainly valuable to make sure that you're appropriate in that, but you're addressing them, because that could be a rate limiting step. And then please do reach out to other programs. So there's lots of programs out there that are in the literature that have implemented this and use different methods, and certainly have been very successful and published about it as well. So I encourage you to reach out to those folks when you're doing your literature dives, and just see what's worked for them, because it certainly can be beneficial. So question number 1 over there. So for prevention of redocumentation, does the alert for negative skin testing show up at allergy reentry for just penicillin, or also for amoxicillin, ampicillin, pip/Tazo? I think it's a good question. Just to explain that a little bit more, because the allergy itself is resolved, when a provider or a pharmacist were to be either entering or verifying an order, they would not get the allergy worry or the allergy interaction concern anymore. That would go away because the allergy is considered resolved. Now, that view that we gave you where it says negative penicillin allergy skin test, that is actually the base profile view in Cerner. So if you were to log into a patient's medical record, that shows up right next to their name, and so that is visual on every pane of their EHR. So that is ubiquitous, so to speak, when it comes to that. So the resolved allows you to keep it in the medical record as inactive, but it doesn't trigger any of the alerts or the cross-reactive things. What's the second question there? So, were the N of 6 patients who had a negative test but did not have antibiotics optimized subsequently not done secondary to any provider comfort level or PERSPEC? So that's a good question. From our experience, we haven't had a lot of provider pushback. 2 of those 6, I can tell you, were at the time after the allergy skin testing was done. Sometimes acute things change with the patient, and at that time the providers were no longer comfortable with our initial streamlining and de-escalation plan. We've actually done 2 of these, at least 2 of the 6, when the patients were actually transitioning off of antibiotics or were no longer had the same indication. So we ended up continuing them even though there really wasn't going to be a need for antibiotics at that point. But in patients who have other potential issues, for example, if you have patients who have chronic infectious disease issues or immunocompromised, or maybe they have hardware in place, dialysis patients, et cetera, those that might have frequent high-risk patients for return of infections, this is something that we're really pushing for now with our expansion, to test those patients as well, because, hey, I mean, resolving a penicillin allergy is really going to impact people. And that's what I tell people a lot is, yes, Stewardship or ID Consult might feel comfortable to say, it's okay to give them cefazolin with that mild allergy. it's okay to give them ceftriaxone with that mild allergy of penicillin. That may be true, but we may not see them until 48, 72, 96 hours later. We may not engage them at all in the outpatient arena. So having the allergy resolved either through intense reconciliation, either through penicillin skin testing, maybe with amoxicillin oral challenge, whatever that may be, taking that out of the record or resolving it in the record, I think, can have a lasting impact beyond the so-called antibiotic or ID experts as well. So do you find that insurance companies are covering this test? Is there an ICD-10 for penicillin allergy? We would like to implement this testing in our pre-admission center for surgical patients. Man, what a great comment. So we're going down this road right now. I'll have to share some of this with you offline. So if you can write down my email address, not because it's private or anything, but I don't have it sitting in front of me. So we're expanding into our orthopedic surgery world right now as we speak. And this is something that's come up quite a bit of how you handle those and how you bill for it in certain settings. So I'll have to share with you that otherwise. We do bill for it on the drug side. In the inpatient world, we do not bill for the pharmacist's time. Now, there are other models out there. You may could speak to Jeff Wall and up in Iowa, some other folks, where there may be a shared model perhaps with an allergist. There may be a shared model with an ID physician or attending. You know, some people have talked about how you might have maybe do a mini consult for ID or allergy. Well, I think the problem with that, especially from CMS and others, once you consult during a hospital stay, if you re-consult, you don't necessarily have the ability to rebill because it's kind of a follow-up consult, and that changes the level of care and other things. So it gets pretty complicated, but please do email me and we can exchange and share on that. It's not an easy answer to say, yes, insurance pays, but from a drug standpoint, we are able to bill for all the materials and the drug therapy. And speaking of ortho surgery and elective surgery, it was a good segue to our next question here. So if you know, how do we implement this? Our original thought when this started a couple of years ago was we would have a nurse who would do this during their pre-op visits. Now, one thing you should consider, every orthopedic group and every orthopedic surgeon may do it differently as to how they require pre-op visits. Some base it on high-risk patients, so all high-risk patients, however that's defined, they come in for a pre-op visit every time. Others, you can register online for your surgery. You can register through phone call. You get your screening within 30 days of surgery, and you're ready to go. So I want to say I'm fortunate in this. You know, this is a blessing that I had hip surgery last October, and I have a penicillin allergy, and I went through this exact scenario, so to speak. And I will tell you, you know, if you could have every person show up 4 hours before their surgery or 3 hours before their surgery, you could probably do it right then. But I don't think that that is, for us, the best method because there are a lot of logistics at play there to do it before they show up. So the way that we're piloting this is patients who have a penicillin allergy have a script that the nurse will interview the patient within their 30 days prior to surgery, and they will reconcile the allergy based on a script that we have given them. The nurse will then direct us to patients who, based on this algorithm and based on the answers to the script, who either their allergy can't be reconciled or they should be further considered for skin testing. Then a pharmacist, a stewardship pharmacist, or in our case, it will also be a pharmacy resident, will be looking at these particular cases of penicillin allergies who their allergy couldn't be reconciled, or even if it was reconciled and they were deemed potential for skin testing, those folks we would analyze, and if they were candidates for skin testing, they would be contacted and they would come in for a pre-op visit. Because like one of my orthopedic surgeons said, he said, Brandon, he goes, would you have qualified for a penicillin skin test based on your allergy? I said, no, I'm an exclusion criteria. He said, great, would you have liked us if we called you back for yet one more visit to come in with work and all the other considerations? And I said, nope, I probably wouldn't have liked that. So it's not something that I would have really enjoyed a lot. So he had a good point. That's why we built in the screening. So it's going to happen for us on our pre-op screening visits that they have to come in for. But when we're bringing them in, we already assured that they're going to be getting a skin test. And we're trying to schedule them all on the same day. So we might bring 4 or 5 pen allergic patients in on the same day. And that way, from a resource utilization standpoint, we can go over there and essentially do them on a half day, or maybe in the morning we can knock them out. So what is the cost for the testing? Well, that's a good question. I think when I don't know that all this is proprietary. I'll give you a ballpark. That's excluding personnel time. That's excluding time to make the product. That's excluding time for delivery and everything. Your total cost of your product and stuff is less than $200. So I think there's a poster at ID Week. Bruce Jones is doing a poster at ID Week that is looking at some of the costs related to this. And that I would encourage you to check that out because it will give you a little bit more information. But we find that from a cost-benefit standpoint, the examples I gave you, it wouldn't take very long to show how beneficial this would be from a cost standpoint based on some of the qualitative interventions we were able to make. We have not done our own cost analysis. We do have a time analysis that we will be presenting in October at ACCP, which kind of goes through how long it takes to do allergy reconciliation, how long it takes to do the follow-up and the order entry, and really walking through that way. That way you can use that data to at least estimate with your group what a personnel cost might be. That's a good question.
So, Brandon and Hana, this is Marnie. I wanted to ask a follow-up question as well, and I encourage our participants to continue. We have a few more minutes if you have a burning question that you would like to ask our terrific speakers. I don't know if you can get to slide 39, but 39, but that's your data slide that you presented. And I was curious, it said that you had 146 consults, and this was basically, it hasn't quite been a year, but I'm wondering what the denominator was do you happen to have an idea of the patients that basically came through your system, what the 146 represents, what percentage, is my first question. And then the second one is, with the allergy reconciliation seems so important here, do you have some sort of standardized question sheet that you have trained your providers to administer?
Good question. So the denominator here, so these were actual consults that were entered into the system. So this is when a penicillin-allergic skin test consult was ordered that we had mentioned through Cerner. So that could have been through a provider or through Stewardship, ultimately through a provider. So from a denominator standpoint of how many patients we actually see, I mean, that number really trumps this significantly because we're seeing, 30 to 40 patients on Stewardship a day and averaging right now 6 to 10 ID consults a day. So that number is small, but you have to remember this was only an inpatient pilot, that the restriction was these patients had to be on antibiotics. It was only going to be people seen by Stewardship and ID consult. We have a 650-bed hospital, so when we now expand this, which is now, we're really starting to see a little bit of an uptick in that number. So from a per day standpoint, you can look, that's on average about a consult every other day is how that works out. So from a workload standpoint, that may give you a little bit better idea. But I don't have a better denominator to share with you other than that was the denominator. We capture the people that were consulted, where only 36 actually needed it of those numbers. Good question. And then your other question was the allergy reconciliation part. Yeah, what a good question. So we train a couple of different arenas. One, we have training that's built into our residents, our medical residents, and so we do use kind of a standard key questions to ask and key follow-up questions. A lot of folks are taught to do open-ended questions. Well, that's appropriate, but sometimes you have to ask closed-ended questions as follow-up to make sure that you're hitting those highlights. And if anybody wants to email me, I'm happy to share that form. It's not overly complicated, but I'm happy to share that form that we give, which is nice. What is the time frame with the testing and the results? So the testing itself is about a 45-minute to 50-minute process from start to finish. That's at the bedside doing the two-step process and interpreting the results. So the results are real time. Based on the package insert and based on the available data, it's a 15 to 20-minute waiting period for the results to return, and your results are immediate there. Now, if you're doing an amoxicillin oral challenge afterwards, which you have to decide if that's appropriate for your patient population or your individual patients, then there's an additional waiting period beyond that, of course. But the good thing is the results are available right then. Do you plan to involve nurses in future initiatives? Well, we definitely do with ortho because we feel like they can be a great delivery point. So while we're expanding out to ortho right now, we hope that this will become such a big need that a nurse can actually handle this as part of their day-to-day activities. We're simply piloting it because they don't have the designated personnel to pull away right now. But our ultimate goal is that, for example, in our GI clinic and our ortho clinic, and perhaps even an OB, that we would be able to utilize nursing to deliver it. Those would be key nurses. So again, like I mentioned, for us, we didn't feel we could train hundreds or even thousands of nurses. We'd have to retrain them every time, and we'd have that duplication of work conflict that we try to avoid. And so this would be targeted nurses in these really niche areas who they're the ones who are always doing it and owning it. But just like everybody else, there's demands on time, and there's certainly things that we have to demonstrate that this is going to be helpful and effective for them. Real quick, I know we're out of time, but so interesting. We looked for 3 months at our hip and knee elective surgery. 18% of them had a documented penicillin allergy. And we do a lot of hips and knees. 18% had a penicillin allergy. Now, I have no idea the reactions. That we were just looking for a ballpark number. But I mean, when you're doing 800 to 1,200 surgeries and 18% people have penicillin allergy, there's a potential for a lot of impact there. Thank you.
Thank you. Yes, unfortunately we're out of time, so we're going to conclude today's Antimicrobial Stewardship Project webinar. And it's a terrific webinar today, as many of our participants have even commented in the chat box. I just wanted to thank Brandon and Hana for their time, their terrific work, and look forward to your future presentations and publications. And I do encourage our participants to reach out to them if they would like to follow up with them regarding any of their resources or input. Just reminding everyone the webinar was recorded, and look for that on our website. And just really to thank our participants for joining us today and your fantastic questions.
Thank you so much again. This was wonderful.
Thank you.